Hey everybody, Kendra the Vet Tech here with a little mini in-between episode. We are going to go over a case report. So my guest again this time, yes, is Molly. And if you heard season 4, episode 1, you might recognize that name. If you're watching us on YouTube, recognize that face. So we're not going to go over Molly's history again. If you're curious about that, you can go back to that episode and listen to the long and short of it. But welcome again, Molly. So glad to have you back with us again.
Yeah, thank you. I love talking about cases and horses, and I think we share a pretty interesting
Dynamic.
dynamic together.
Yes.
Yeah, yeah.
Yes. So had some good reviews and feedbacks about the case report, people that are in school and happy to hear about these cases and put some sort of real life application, some meat to the things that they're learning that are circumstantial in school. So we're going to try this out, see if you guys like it, and maybe carry on once a month meeting up, talking about cool cases that we see. In honor of foaling season. I've done a lot of things in honor of foaling season. Yeah, lately. That's what it's all about right now. So in honor of foaling season, today we are going to talk about Mare Dystocias. Really fun. Something, Molly, that, we were discussing this topic, something that I don't know if it was covered in school and just one of those little things that kind of escaped somewhere along the way, but controlled vaginal delivery is not something that I really remembered learning a lot about. So, there's Mare has the foal naturally, unassisted, or Mare has the foal with just a little bit of assistance. And then there's like this black hole where controlled vaginal delivery fits in, and then all the way down to C-section. So today we're going to fill in that black void if anybody else had that black void as well, and talk about a case that was a controlled vaginal delivery. So Molly, I will turn it over to you to get us started here.
Okay. Well, we're gonna throw some visuals in. I've got some photos that Kendra can throw up for you guys.
Yes.
Everybody loves a good pictorial, and this is where I'm going to kind of rib my host here. Do you want to share your picture of when you were prepartum?
Oh Lord. Yes. So
Maybe.
Yes. So here is a photo of me when this was taken when I was moderating the conference, Pacific Northwest Veterinary Conference, and I was 1 week before my delivery date. So very large. And yes, sharing this picture. I did share it on my social media at the time, so it's not super embarrassing, but yes, I feel for these mares. Very much.
And I haven't had the pleasure of being that blessed, but I do feel for them. And when I saw that photo, I was like, this is perfect.
In the spirit.
No shame at all. Just mostly we get it on a very personal level.
Yes.
Kendra more than others. Myself. Anyway, so our patient presented to our workplace at 11 p.m.
Yeah, this was in the dark of the night.
The dark of the night on a Monday. So Monday going into Tuesday. Her history was that she began showing signs of labor between 4:30 and 5 p.m. that evening. And I know that a lot of my southern neighbors, Kentucky, I'm looking at you, are like, oh my God, why was she in labor for so long and nobody did anything before coming to our workplace? And I'm going to show this quick photo, and you'll see kind of the state of Indiana and its elongation. And there's a couple of different spots on here of veterinarians or practices that have the capability of doing kind of advanced addressment of parturition issues. So dystocias, right? And the capability of doing cesarean sections. And it's not so much that other practitioners in the area can't or shouldn't or won't, but these are the ones that I know of with my connections, and also that we have the facilities and the capability of taking these cases on. And that there are plenty of practitioners, despite the veterinarian shortage, I should say that, despite the fact that it is hard to get your hands on a veterinarian to come out to your farm, especially without a previous VCPR, there are plenty of veterinarians in our state who can address these issues. And from what I understand, kind of as a side history, was that this patient went into labor, the owners assisted up to their capability, and then they called out their personal veterinarian, expressed that they did not want to take their mare in, that they wanted him to do everything possible that was within his capacity there, recognizing that by the time that he arrived, the foal was likely already dead, and they kind of made their peace with it. and the veterinarian got to work. Now, I don't understand, like, from the time that she left stage 1 labor into stage 2 labor, that they got him out there. Like, was it immediately within 20 minutes? Was it within an hour, 2 hours, 3 hours? But the referring veterinarian worked to reposition the foal with the mare either in a standing position or with her laying down unsuccessfully. And the owners were very insistent, do everything you can, do everything you can, do everything you can. So by the time they made the decision to drive in, enough time had passed, and then they had let me just double check this real quick, easily a 2.5 hour drive.
Yeah, I was going to say,
Okay.
I feel like they were really far away.
Yeah, pretty far away. And so, and you'll have that. And then kind of alternatively, or as an aside, there is a large Amish population in our state that we need to kind of respect their limitations and the fact that they rely heavily on working horses to be able to survive. That's their livelihood. But they don't necessarily have the means to just throw their horse in the trailer and come to us immediately. Yeah. They do have to secure transportation and then come from these areas where there's a heavy Amish population to some of the few places that are in town. So I just kind of wanted to address that, just because I know everybody's like, this is the textbook thing, but recognizing that owners can't always do things textbook wise. So there's that.
Well, and I would also like to just make another generalized public service announcement. You know, you had said that finding a veterinarian that we have the VCPR with, and that's a real thing right now with the shortage of equine veterinarians, that even just for a simple your horse colics, nowadays some veterinarians are so swamped that they will not come out for even emergencies for you if you do not have a VCPR with them. So it's really important, regardless of what you're doing with horses, that these days you do make sure that you have a regular veterinarian that you see once yearly, get that relationship established, so when you do have an emergency, you're not stuck without someone. So that, just not related, public service announcement, because that thought had occurred to me when you had specifically mentioned that.
Yeah.
Anyway, back to our case.
No worries. So I'm going to kind of go on kind of a little tangent. I want to say, like, oh, I'm a rule follower. That's not entirely true. I live in the area of gray.
Yes.
The vet med is gray, right?
Yes.
Like, we just have to be very gray about our black and whites. But one thing that I'm pretty passionate about is a standard operating procedure for emergencies, so that people know what's supposed to happen, when it's supposed to happen, and who's supposed to deal with it.
Yeah.
So when, like, our kind of policy with dystocias, but this really does wrap up into a lot of our emergency receiving. The resident receives a phone call from the answering service, who then patches them through to the referring veterinarian. When we hear that it's a dystocia, or when the resident hears that it's a dystocia, they are to get all of the history, the signalment, the history, as much information as they can from the referring or the owner, including, meds that were given, how long this has been going on, what has been done up until this moment, and then an estimated time of arrival. What they'll do while they're getting all of that information is they'll make sure that the patient's entered into our computer system, so we don't have to muck around with that when the patient arrives. We don't have to deal with all of the computer paperwork and this, that, and the other. We just get a signature, whisk the mare away, and start addressing the issue.
Yeah.
Once they're off the phone and they have an ETA, they call in kind of a phone tree. And so that is a senior clinician, so their senior faculty, who's in charge and on that night. And in this case, it was our emergency criticalist, Dr. Jameson. And because it was a dystocia, Dr. Justin Hana, who is our theriogenologist. Then the resident contacted the on-call technician, that was me, contacted the night technician, that was Kendra, contacted our students, who are required to be there to assist with patient care and receiving and learn and all of those things. And then also contacted our anesthesia technician on call. And actually, it was Dr. Murillo, who's a resident.
Yeah, I remember seeing her.
Yeah, so that night it was Dr. Murillo, not a technician, but a resident. And that's kind of like our little bare bones crew that gets called in.
Yeah.
There's also an established protocol saying, like, make sure you call your fellow residents. And that's how internal medicine got involved. So the internal medicine resident that was on call came in. And because the criticalist, Dr. Jameson, is an internist, we didn't need to call in anybody else. So we had our, like, little merry band of veterinary team. And what we do is we had a 2-hour notice, and I was
Yeah.
like, do you want me to come in and set up early and like take a nap? And he says, no, I'll call you when they get like a half an hour out. I was like, okay. So I got as much sleep as I could, and then rolled out of bed as soon as he called, grabbed my tea and hit the road. Once I got there, maybe I'm a little too much of a boss. I don't know. But like as a senior technician, I'm like, all right, I got a bunch of students and we got a lot of stuff we got to get set up in a very short amount of time.
Mm-hmm.
And there is nothing I hate worse than having my pants down around my ankles when something shows up. So I
Yeah.
started assigning tasks. That night, Kendra was pretty swamped with cases. So
Yeah.
I didn't want to pull her away from other patients that needed her attention. So I got the vet students getting stuff set up. And so what this looks like is I go in my brain, kind of like in sequential order. The mayor's going to walk in and I tell the vet student, you're going to be in charge of getting the history. And I look at the other vet student, I say, and you're going to be in charge of getting the physical exam. We're going to divide and conquer. Meanwhile, I'm going to be in charge of getting the IV catheter in place and getting some blood. And we'll get a CBC chem fibrinogen plus a lactate and suffer an immediate blood gas. And we can put that CBC chem fibrinogen off to the side just in case we need it later, but we'll definitely run a PCV total protein lactate plus minus a blood gas if needed. So we got all of that stuff set up. Then we have to worry about what I call like the butt side.
Yeah.
That's Dr.
Yeah.
Haynes. So we got a warm water bucket, a bucket lined with plastic because you never know what was in that bucket. You don't need to contaminate that business. Warm water, pound cotton, ivory soap, and or betadine solution. And that's just to cleanse the vulva.
And just important side note here for people who might be taking notes is that stuff's not going in the water. So this is a clean water with the roll cotton in there for you to practice clean hand, dirty hand. So you have one hand that always goes into the bucket, touches nothing but the innards of the bucket. Yep. And then you have one hand that'll be on the outside that will get soapy, dirty, gross. So the point is that we don't have two buckets or we're not contaminating our bucket. So then we can use that bucket to wash, but also to rinse. So that's just a important explanation, I should say, of how that bucket works.
Perfect tech tip. I love it.
Yeah, tech tip.
Clean hand, dirty hand method always. Oh, and you got to tie the tail. I completely forgot. Before you even wash the vulva, tie that tail.
Yeah.
Wrap it with vet wrap or roll gauze, whatever the practice protocol says. Wrap it, and then you're going to tie that off to the side using either a rope or another gauze, and then wash.
To the side, to the patient.
The patient.
Please do not secure tails to things besides the owner of the tail.
Yeah. Do you want a tail at the end of this, or do you want a tailless horse?
Yes.
Black Beauty had a tail. Let's keep them beautiful.
Okay.
It's a very good point. Sorry, back on track.
Tie up the tail, get our bucket, cleanse the vulva.
And now you've got to do what? You need to assess what's going on intravaginal. And so depending on the veterinarian's preference, they may wear sterile OB sleeves. So you need to have those. And they may choose to just wash their hands and arms really well, make sure that their fingernails are clean. And those individuals may or may not then just soak their arms in betadine. And Dr. Haynes prefers to just wash really, really well with respect to making sure that his hands and fingernails are clean and have the dexterity for palpation. Mm-hmm. Totally makes sense. Mm-hmm. From there, with the assessment that the veterinarian does, then OB chains can be placed around the limbs. I'd have been a really good instructor if I brought something home to demonstrate, but that's going to be using like a slip loop that's going to go around the cannon bone proximal or above the fetlock, and then a half hitch around the pastern. And that prevents there from being one area on the limb that is taking all the pressure. It basically spreads out the pressure from the pull, and then you have less of a risk. You have less risk of causing fracture or dislocation of a joint. Then you need some handles, and from there, it's time to set up for baby. So my big thing is, I don't care how long that mare has been in labor.
Yeah.
We need to prepare as if the foal is alive, because I have been in situations where the resident said, it's fine, but it wasn't fine.
Yeah. Talk about having
And
your pants down, like no oxygen,
that
no suction, no towels.
nothing. Yeah, this was before we had our like nice little SOPs in place, and everything was just a little chaotic back then. And so I'm
Yeah.
really grateful that we have like an established understanding of how to do things. And so what that looks like for full receiving, at the very least, your team needs to have towels to catch full. You need to have a method for suctioning out amnion from the airway, and to establish an airway, so, or to deliver oxygen. Now, in our facility, we have the benefit of doing flow by oxygen from our oxygen system that we have. We also have mobile oxygen tanks with flow meters and adapters. And I think that that's probably, these little oxygen canisters with flow meters can be something that trucks can carry. And I really wish I could remember the name of this product, but there are kind of commercial made ambu bags that first responders have in their
Interesting.
arsenal that practitioners can get a hold of and actually take on their ambulatory system. So you don't have to have a fancy facility to be able to provide proper resuscitation technique for fulls.
Yeah.
Right. From there, you also need to have drugs. So at the very least, epinephrine and Dopram, epi for kickstarting that heartbeat, and Dopram to kickstart the respiratory center and get them breathing on their own.
Yeah.
Everything else from that gets really fancy. So our department makes sure that the ultrasound is in place. We have neonatal catheter stuff set up, so that would be an over-the-wire catheter system, ECG, including a monitoring system.
Yeah, I was going to say, we have the fancy monitor,
Yeah.
EKG, blood pressure, SpO2. It's got all the little bells and whistles on it.
Yeah. And so from there, you just really need a mare and your team. My big thing is system. So when the mare presents, we get 5 minutes to get the catheter in, which includes also physical exam and history, right? Like we don't really muck around too much. Like when was the last time your horse's hooves were trimmed or whatever? We don't really worry about that.
Yeah.
Pertinent history only. We also need to establish, and this is where the residents' communication really is required, because they are the ones that do the intake. We need to know, like, what's the plan? Is the mare going to be used for breeding after this, or is the foal's life more important? Is the mare's life more important? Those things really need to be established.
The hard questions. Yeah.
Yeah. So yeah, 5 minutes to kind of get those things done. And then from there, I really start the counting the clock, and I just kind of, all right, it's been 5 minutes. Look down, it's been 10 minutes. So catheters going in, we're doing vaginal palpation, and we give them about 15 minutes to decide, can we get this outstanding, or do we need to move on to something different?
Yeah. So I guess a question that I have, Molly, is with this particular case, so, we've already established that this mare had been in labor for quite some time, and the foal was likely dead. But even if we weren't really sure, we're still allowing them the 15 to 20 minutes, right, to see if they can manually manipulate it. Because I know that's the standard is 15 to 20 minutes in equine birthing period. We give them 15 to 20 minutes to get the little booger out, and then it's emergency time. Okay, so we still went 15 to 20 minutes with this mare, even though it had been prolonged.
Yeah. And what I will say about this is Dr. Jamieson did apply a transabdominal ultrasound to confirm that there was no blood flow in the uterus. And so we did confirm that the foal was dead. So there was a little bit more of an allowance, like, okay, well, our assumptions are correct.
Yeah.
Unfortunately, the fetus is dead. We need to provide some options for the owner.
Yeah. And this was that night, that operation, that's how it went, man. You guys got the mare in off the trailer, got a weight on her. She went right into induction and recovery room and right to work. Everybody was there, had all their little duckies in a row, and went to work on it.
Yeah. The hang up was somehow there was a miscommunication between the owner, the referring veterinarian, and our resident, that the owner did not want to do a cesarean section, just wanted a phytotomy. And none of that was translated. So when we called to get permission to take the mare to to induce the mare for anesthesia, controlled vaginal delivery, and if that was unsuccessful, then cesarean section, the owner balked and was like, no, you can try controlled vaginal delivery, but we don't want to do cesarean section. It's phytotomy only. So had a little bit of a debate there. So we did have a lapse in time while the communication was being figured out. Not a big deal. That allowed for us to start intravenous fluids on the mare to give her a little bit of reprieve from all of this labor that she had done,
Yeah.
with no help, basically.
Mm-hmm.
Once we had permission for general anesthesia, the anesthesiologist went ahead and anesthetized the mare. And so we know natural birth mares lay down in lateral, push, and the foal comes out. And the foals are supposed to come out like a staggered Superman,
Yeah.
their shoulders kind of off to the side, doing this. And this little guy, what Dr. Hana was palpating, was that the foal's neck was flexed to the right and then deviated ventrally. And when I asked him what that looked like, he just kind of did this. So the foal was dabbing, basically on its way out. If that's the butt was doing this. So he was not at all in the correct position, unfortunately. And so with her standing in normal standing, there was too much tension on the pelvis and kind of the surrounding birth canal to be able to repulse the foal backwards, lift the head up, untangle him from his little dabbed legs. And so that's where controlled vaginal delivery comes in, because even laying down in lateral, if you could get the mare to lay there with all of the things that are happening and the fact that she's in a new environment, she's not really going to want to lay down on her own. It'd be very hard to get that pelvis to kind of relax enough to get the foal out. So this is where controlled vaginal delivery comes in. And the idea is that you anesthetize the mare so they're relaxed, right? And you have control of the situation. But then what you can also do is hoist the hind legs up so their bum is in the air and all of their heavy viscera moves forward. And there's all of this space now in the pelvic region to be able to push the foal back, bring the legs forward, and then get them in the correct position to pull them out with minimal trauma to the mare. Like maybe standing, they could try to get the foal out, but all you end up really doing is traumatizing the birth canal.
Right.
So do you have any questions about that?
No, I just, my comment was going to be, I feel like that is just such a cool kind of middle ground space to where, before we go to the extreme of saying we can't get the foal out, we're just going to cut. And I just love that we have this middle ground in certain facilities where we can just anesthetize them, relieve the pressure, do some manipulation, and get the foal out with minimal trauma to the mare, and then of course not having to do major abdominal surgery on her. So I think that's fantastic, and a good explanation of it. And
here's a picture.
Yes, the picture.
So, yeah. And so you can see the hoist is literally lifting the bum up and the entire team is getting ready to pull. And this one was a particularly big pull. And it, I think, makes me a little uncomfortable because I don't want to participate, and nobody in the veterinary team wants to participate in damaging the mare further. But in this case, she did not have a surgical option.
Yeah.
The owners could only afford doing controlled vaginal delivery. So the resident worked really hard in getting the foal into a correct position. And then we just had a bit of a rough pull.
And sometimes, guys, that's the reality of what we do is some owners, and it's best for them to be upfront. It's great that they are upfront and say, look, I just don't have the money to go this far, and that's totally fine. But, unfortunately, sometimes those are the circumstances that we're left with, is maybe you will cause a little more trauma, but it is what it is at the end of the day.
Yeah. Yeah. And if it is, what the owners can afford and it's going to be able to allow the mare to live.
Yeah, definitely.
These are kind of the choices we make. Yeah. And let's be really honest, like horses breeding, very violent. Mares foaling, so violent. There are so many like birth-related injuries to both mom and baby.
Yeah.
So what we do is provide the opportunity to reduce the injury that is inevitably going to happen.
Yeah. Because last year we had one that like kick punched its way out and just like shredded everything on the way out.
Yeah, like that baby was coming out violently.
He
didn't even hit the ground.
For sure.
Didn't even hit the ground. Didn't even have time to choose violence. He just was violence.
Oh, Lord.
Violence incarnate.
This little mare, though, fetus, the foal was deceased, but they did get it out. And then placenta came out shortly after. It was found to be fully intact, which is always great. And that's another big part of the postpartum time for a mare is delivery of the placenta. Yes. So delivery, make sure the placenta is delivered. But then second is we always want to examine that placenta, make sure it's fully intact, that we don't have any retained pieces in there that are going to cause us problems later.
Yeah. And what's really helpful is when you lay it out in an F position, like you can see in this photo, you can even fill it with water from the hose. And if it holds, you don't have like a microscopic tear with a potential like shred of fetal membrane left behind in the uterus. And as you know from mares, you look at them funny and they founder.
Right.
They get sick and they get laminitis. And so it's really important to make sure that like that placenta is intact and there's nothing left behind. So anyway, at this point, we successfully got the foal out. And she recovered without incident. I got to go home and get a little bit of sleep. Kendra got to take care of her postpartum.
Yeah, so she was a pretty easy postpartum care because she did already have her placenta delivered, fully intact. So she was just kind of a standard, recovered from general anesthesia, placed her in a stall, and when she was fully awake and fully with it, we gave her a nice little senior mash to help her recover a little. And then her care after that was just oxytocin every 4 hours, and they did some uterine lavage during the day. She was actually only with us for a total of 48 hours. She went ahead and went home, and so I only had her a couple nights, and things were pretty uneventful. The oxytocin was to really help that uterus start contracting down and returning back to a more normal, natural state. So she was a pretty low maintenance postpartum patient for me. She did well and went home. She got a little uncomfortable the second night from all the oxytocin. We discontinued it at the end of the day. We discontinued it because she was starting to get a little uncomfortable. I didn't feel comfortable giving her another dose because she looked like she was having a little abdominal discomfort. And so I just spoke with a urogenologist, had a conversation about that, not wanting to add insult to injury. So we discontinued it at 4 a.m. and then she went home the next morning. So recovered pretty uneventfully.
Do you want to explain what oxytocin does?
Oxytocin is a hormone that, so we use it for a few different things. It can be used, like I just talked about, in the reproduction postpartum to help that uterus kind of shrink back down to where it's supposed to go. And then the other thing that we use it for is for milk letdown. And we'll do that in lots of different species, and we can give that, and then they'll let their milk down for us to be able to milk them or for them to produce for their baby. And we usually give that intramuscularly. So it's a pretty great drug for that. I even used it growing up on dairy farms with cows that were a little shy in the parlor. We'd give them a little hit of oxytocin so that they would let their milk down for us. But
I did not know. Little young Kendra just want some oxytocin.
Popping things with oxytocin.
I know. Drug dealing when you were a teenager. Yep. I should not have said that. You should censor me out.
Not that kind. So we use it for a few different things. Definitely our postpartum things.
And for our listeners who have massive cramps monthly, think of it like a really, really, really bad cramp.
Yes.
In your uterus.
Yeah.
That's what it's like. So I do remember you talking about her getting a little colicky that night. Not unexpectedly. Yeah,
exactly. And I see that sometimes we do this frequently for our postpartum patients to really help the uterus contract. And I see that from time to time where they just, we're getting to the last couple doses of it and boy, they just are already really uncomfortable. So I'm like, I think it's doing its job. Can we maybe hold off on a dose or so and see how things go? So,
yeah. And so compliments to our treatment team for being able to have those conversations with doctors. I think that there's kind of this idea that the doctors always know best, and they do. They just need to have all of the information available to them, and so that's why
it's always worth the conversation. I've also had instances where they're like, no, because I distinctly remember a goat that I was like, man, I just don't know. I don't know if we should keep giving this to her. And they were like, well, let's just stay the course. She only has like 2 doses left. She's otherwise bright and doing fine. Carry on. So sometimes it's not always, that's fine. We'll be done with it. And there was I can't recall the full case on that goat. I've slept a few times and had a few goats since then, but I'm sure that goat probably also had a little bit of retained placenta. So I'm sure that's why we stayed the course with her, whereas the mare we knew did not. So it was easy enough to just wash our hands of it and be done with it. So it's always a case by case, but it's never a bad thing to speak up. So.
Yeah. Well, so speaking of postpartum care that maybe isn't going so swimmingly, do you want to talk about our other dystocia case that we had together?
Yes. So we recently had another one that I actually don't know. Was that one?
Oh, wait, you weren't there because it was during the day.
Well, I wasn't there for the delivery, but I met the little devil spawn for care.
So mean.
Care after. Yeah, she was very evil, biting and breaking skin, rearing and striking. She was quite evil. But
all 150 pounds of her,
yes.
By the way.
That makes it hilarious and not quite as scary sounding when you do state all of the facts. Yes, so she was very tiny, but she was a little different in that I'm not sure the full status of that. So we were concerned about retained placenta on her, I assume, based on
30
what I was
seconds
doing.
or less. Yeah, unfortunately, this mare had been in labor for over 20 hours. We don't judge clients, right? Yeah. So she had a very dead fetus, very dead foal. We all knew. You smell it when you walk in, right? And so even though she passed her placenta normally, there was a lot of contamination
from the fetus.
In the uterus. Yeah. All of those fetal membranes were rotting. The fetus had not been alive for quite some time. So, Dr. Hana and I think it was Dr. Taylor at the time were both quite concerned with a potential metritis. Metritis, as you know, along with all of the other itises that horses get, are one of the life-threatening complications, or one of the many life-threatening diseases that horses get. One of the complications includes systemic inflammatory response syndrome, which leads to multi-organ system dysfunction and laminitis. Take it away, Kendra.
Yeah, so with that mare, it was drastically different, a lot heavier care on her. So they were doing their daytime things, uterine lavage and exams on her. But then the other thing that we were doing for her was fluid therapy. So she had an IV catheter. She was on IV fluids for at least 48 hours. And she was also on antibiotics. So she was on potassium penicillin G. So we give that IV slowly. She was also on oral antibiotics, metronidazole. And I'm sure they had gentamicin thrown in there. And
definitely.
The usual flunixin. And then she was on, oh my goodness, oxytocin. We just talked about this. I just had this word. I was like, the word has left the building. So she was on IM oxytocin as well. And she was one that, we were staying the course and keeping that going because we really wanted those contractions in the uterus, expelling anything that was left in there and really contracting that uterus down. And she was quite the pill for all of these various things, but we got it done. And just a little more intensive case from the treatment side, from my side. But and then we were also doing things like slowly refeeding her as well. We've actually done that on all the ones that I've been party with our new theriogenologist. He really likes to slowly refeed them back just to make sure nothing has shifted and we're going to run into a secondary colic episode. So we do slow refeeding. Yeah, slow refeeding on these mares. And I appreciate it. I think that's a great idea. Yeah. And seeing the big picture, that it's not just focused down on this event and you got to take care of the whole horse. So, but Molly, what if we're not so lucky to be able to get the foal out? We were going to focus on controlled vaginal delivery, but while we're here, while we're talking, can we do a super quick breakdown of if we're unsuccessful getting that foal out?
And I also want to shout out to practitioners and technicians who work in the field. There are methods to be able to do controlled vaginal delivery without having the fancy stuff. I do want to kind of just recognize that there are many ways of doing the same task and it accomplishes the same thing. And so what they do is a triple drip anesthesia out in the field, tractors with hobbles over the mare's legs to hoist up her bum. Same concept, right? So You can't get to a referral facility. You can't, like, I don't know, you're 5 hours away. Montana is a massive state with very few like surgical options. So,
So we did talk to Eli from
okay.
Montana
Yeah.
an episode ago.
Hi, Eli.
He filled us in on the lack of resources in Montana. So
Yeah, like rural vet med is no joke. And
Yeah.
so, like I'm a wiener. I want to work inside. I get it. There are some pretty big people that have big cojones that can do some pretty rad stuff. Same stuff that we do, just in different circumstances. So
Yeah. Okay.
there's that. I have not heard of too many people doing cesarean sections out in the field, but I have heard of colic surgery by headlights. So I'm sure that it has been done. I know. Not me, not in my career span, but
Yeah.
in any case. So if controlled vaginal delivery is not an option, or if it is imperative that the foal come out as fast as possible because their life is more valuable than perhaps the mare's, right? Cesarean section is an option, and we treat it very similar to colic surgery, where the patient is anesthetized, positioned on the table in dorsal recumbency, and we clip the abdomen. But we make sure that we go all the way back, practically to the perineum, because the surgeons are going to cut basically from umbilicus all the way through the udder, transecting the two planes of the udder, because they got to go pretty far back to be able to exteriorize the uterus. So surgeons, again, time is of the essence. So when we know that we're doing a cesarean section, one technician will go into the OR and start setting up, like opening up the tables and getting the instruments set out and ready. The other circulating nurse will clip and prep the abdomen, both rough prep and a surgical prep. And then they are rolling in. While all of that is happening, the surgeons are scrubbing in, gowning up, gloving in. They're getting their table ready. The mare rolls in, anesthesia's doing their thing, rocking and rolling. Surgeons immediately drape the patient, open the abdomen, exteriorize the uterus. And that's really important because you don't want those uterine contents to spill into the abdomen. You're looking at a really ugly peritonitis and likely a dead mare at that point.
Yeah.
So exteriorization of the uterus, control the spillage of those uterine contents. Once the uterus is open, the foal's limb, whatever limb they can find, back leg, front leg, is going to be pulled out, a chain applied, and then immediate tension pulled by any of the people waiting in the wings. So you're going to hold that up. And then the next leg is the same thing. Chains, we have to recognize that my shoulders are terrible. And that mare is usually sitting at this height for me.
Yeah.
And how many stools I've got, I can't lift like 150-pound full up out of the abdomen. Lots of draft horses in Indiana, by the way.
Yeah.
So we do have a hoist from the ceiling. Throw the chains over the hoist. The hoist pulls the foal out of the uterus. The medicine team grabs the foal and carts that off for resuscitation. And the surgeons get to going to suturing the uterus. And I've got some photos here that we'll share.
Yes.
In this one, there's the baby on the hoist coming out of the abdomen. And you can kind of see everybody's ready to like catch with their towels. Where's it going to land? Dr. Luskin, I believe, is doing a whip stitch over the uterus, like the multiple layers of the uterus to prevent excessive bleeding. That's a huge problem with a very vascular uterus. They want to get everything kind of controlled. And then once that whip stitch is done, then they close the uterus. Lavage the uterus, make sure all of the blood is not sticking, make sure that there's no damage to any of the viscera. So they might run the bowel if there is a suspicion that maybe there was perforation in the uterus or some sort of kick by the foal in traumatic events, right?
Yeah.
And then they close the abdomen, and then the mare recovers. And in many instances with a cesarean section, we will have a live foal, and so team medicine is resuscitating foal. Once the mare is up and recovered and the foal is stable, that's a different podcast for a different day, different month.
Yeah.
The introduction of the mare and foal.
Yeah, foals. Ooh, that could take us hours to talk about caring for those little things afterwards.
Months.
Yes.
Months. Yeah. Maybe we'll talk about a foal sometime.
Yes. Yeah. So and that's there are instances. Just in case you guys are like, oh, when would they ever value a baby over the mother? Just think about things like surrogates, embryo transfer, guys, where that dam is not technically biologically related to that foal. This is probably a very expensive egg and some very expensive semen that have come together to make this baby. And that makes that baby way more valuable than the dam. So,
Yeah.
or than the surrogate, I guess, the surrogate, the horse that was carrying it.
Recipient mare.
Yeah, recipient mare. However you would like to phrase it in that moment. So, unfortunately, there are these sad instances where that's true. The baby is of higher importance than the mother, the mare. And that's just, again, one of those things that you just kind of have to learn that that's the way of the world in this business.
Well, and we had, God, I don't know. I just think that we see some like pretty ugly things in vet med and we don't really think much of it. So I do apologize sometimes for my dark humor that you guys might see. We did have a really unfortunate case where the mare had a really ugly enteritis. Something had happened and she was sick. And it was going to take a lot of money to even stabilize her enough to be able to have this foal. And she was due any day. And the owners had to make the tough decision. Do we invest a lot of money for a mare that likely would die and potentially take the foal with her? Or do we do a terminal C-section, recognizing that's probably what's going to happen to the mare anyway, and invest that money into caring for the foal? And they ended up doing a terminal C-section, and the foal went on to live, had a bit of a rough, 24 hours, but
I'm sure.
The cool thing about I wanted to say the human body. I mean, it happens in humans too, because a uterus is a uterus, right? But like the cool thing about nature is that when the dam, horse, human, whatever, is under stress, there are a lot of hormones that are released to prepare baby for imminent birth. And that's what you can kind of call like a precocious fetus, as they come out with hair when maybe you weren't expecting there to be hair. Their limbs might be more developed than they had expected. And so this foal had been under an undue amount of stress and was more prepared for life, even though it was technically a premature foal. So there's a lot of instances where it's like kind of ugly, but you do get something pretty cool out of the situation.
It's what it is. Yeah. But then when they go home and you have
isn't that
pair,
fun though?
It's great.
Yeah. I love full care, even though I'm not really doing it too much these days. So
all right. Well, I think that wraps us up for today, Molly. We covered top to bottom, a few extra things in between. That's all right. Things that weren't expected that came up that I feel like just kind of filled things out and gave us some extra points and tech tips and things to consider. So I think that's great. Well, thank you so much, Molly.
Yeah, of course.
And guys, we're going to see how this goes, making this a regular thing for you guys. So if there is something more that you would like to learn about, please get in touch with me via my social media, Kendra the Vet Tech on Facebook or Instagram. Feel free to email me at kendrathevettech@gmail.com. Anything you'd like to learn about, we are large animal technicians, so recognize that. Only taking large animal requests.
Don't ask me about dogs.
I'd like to know about my cat's diabetes. No, Molly and I will not be discussing that. So anything large animal related that you guys would like to learn about, definitely shoot that to us as an idea. We will try to make this a monthly thing for you guys. See how the interest goes and what you guys would like to learn about.